critical only. My first disclosure, both Anil and my friend, many friends, Dr. Praveen, declined to speak against the motion that is incomplete revasculations or culprit revasculation. Those who have watched this movie, Pulp Fiction, they know what does that mean. The best tactics in the debate, my teacher said, the best way to win debate was to define your terms in a way that favors your side. We are still two good friends, and I'm sure at the end of the day, you'll understand what I'm going to do and what I'm going to practice in real life. Cheap is not this cheap. Cheap is not that cheap. Cheap is not that this cheap too. A cheap is a complex, high risk and indicated patients, and there are many more things to understand actual cheap. You should be conversant with CTO, LMCA, Adusam has on bifurcations, calcium management by Dr. Shamin Sharma. Also, everybody should understand the hemodynamics of MCS, Impella, and ECMO. Rota, laser, IVL, closure device. And CHIP for me is a critical lesion species in highly indicated patients, and it's a complete procedure. This slide was prepared only yesterday, and the concept courtesy by Dr. Vijay Trian sitting here. So S for simple, L for low risk, H for high risk, C for complex. The learning spectrum is not like a black and white, like simple and complex. It's like a northern light. It keeps on changing the hemodynamics, the patient profile, the creatinine, the complexity, and it also depends on the perspective. And everybody sitting here, starting their career, start with a sleep case, simple, low-risk cases, then SHIP, that means simple, high-risk cases, then CLEEP, then CHIP, culprit, then ultimately Dr. Sunita's way, and when you are the best. Looks does matter. The looks of the CHIP can be deceiving. The perspective of complexity can be simple, a simple can be a complex. And you know, day before yesterday, the goal was scored by the Brazil. Somebody can do retrograde CTO better than the antegrade CTO. Somebody can score in reverse. But these people are cocky, highfalutin, and they have inflated egos. And who are these cheap, complete revasculation operator? They have a large bladder, like retrograde CTO, radiation-resistant skin. They ignore their family and friends, ability to gulp complications, ability to withstand death staring at you by the staffs, nurses, do not take back hospital deaths back home, they do not regret. And I'm sure there are many more macho attributes in these people who are doing complete revasculation in cheap cases. There are 10 signs of maturity, let me read it out. Small talks does not excite you. Sleep is better than Saturday night out. Forgive and forget more. Become more open-minded. Doesn't force love. Accept heartaches comfortably. Do not judge others easily. Accept differences of life. Silent on nonsense fight. Their happiness does not depend on others. As you grow old, as you become a mature intervention cardiologist, small vessel lesion does not excite you. Sleep is better than Saturday night cheap out. Forgive and forget non-critical cheap lesions. Become more and more open-minded to medical therapy, FFR and imaging. Does not force love for small vessel CTO. 2 CTOs in cheap. Accept mild angina comfortably. Do not judge easily others' complete revasculation process. Accept differences of opinion. Silent on nonsense fight, and their success does not depend on others. So cheap revasculation, there are many gears, and an appropriate use criteria is the engine oil all the time. You cannot ignore science. So you have to choose the right patient. Patient has the right to choose right doctor, right cath lab, and right strategy. Right reasons to justify complete revasculations, enough of ischemia and enough of angina to prove that you are investing in cheap cases and the patients are paying from their nose. You have to have viable myocardium. You have to have more LV dysfunction, surgically turned down cases, and more complexity. In-hospital mortality increases 6 to 7 times by surgical turn down, 15 times by poor LV function, and 2 to 3 times by CKD. The high syntax score, you can make it, residual syntax score, just doing the culprit only, complex baseline, and if you have a complex goal, then you go for a complete revascularization. I'm a simple man, I have a simple goal, I'll go for a culprit only. Comparative effectiveness of complete revascularization versus culprit, in fact, represent effective comparativeness. So these two patients are different. One can go for complete, but other one definitely will go for a culprit only. What is cheap democracy? Cardiologists born equal? Oh, really? They are not born equal. But do they have same skill, right? To do complete revascularization, revasc? Do patients think that all intervention cardiologists are born equal? No. Indication to do cheap complete revascularization instead of culprit staged PCI does not change just because lesions are harder to treat. And one size fits all? No, definitely not. And anatomical extent, severity of disease associated with mortality, complete revascularizations is just a pedantic dogma, and complete revascularization for all is a leap too far, especially in Indian patient where price is a constraint, the access is a constraint. And look at the patient, and everybody is forcing do the complete revascularization. Your colleague, your nurses, the hospital authority. The conventional wisdom in the modern era, culprit only cheap. Patient can choose culprit, complete revascularizations. And data are everywhere. Everybody is watching you. You are being watched whether you know it or not, don't know it. Every wall has their own eyes. Hospital authority, state health agencies, insurance companies, rival colleague, and the public at last. We can use Impella to put this patient back on safety, but it comes with lot of cost, and we are also talking about affordable cardiac care. Conventional wisdom regarding the cath lab, less is sometimes more. The healthcare budget, 1 hour agony of culprit only is for stage cheap on 2 occasions, far better than 4 hours agony of the relatives outside the cath lab. And sometimes this cheap complete revascularization takes a lot of time. The surprise can come retroperitoneal hematoma, acute stent thrombosis, and AKI. So let's talk about the real DeVive BCS2 patient, 85 years male, diabetic, COPD, creatine 2, ejection fraction 25%, severe MR, moderate tear, high PA, surgically turned down, NOIH class 3, angina mild, a frail candidate, left ventricle 50%, calcified, proximal 70%, circumflex 80%, RCA calcified 80%, long diffuse, old inferior MI that could be causing mitral regurgitations. MRI showed 4 viable territory, good femoral access, affordable, willing for MCI, willing for MCS, and complete revascularization. There are 4 choices, ladies and gentlemen. You can go for OMT, you can go for OMT plus protected PCI, you can go for OMT plus complete revascularization, Dr. Sunita's way. You can go for critical revascularization and you can stage it. And here is the lesions, Impella, and at the end of the day, I forgot the RCA, so I did circumflex and the LED crush technique, and just do it, LED circumflex, shut your case, go home, forget the RCA. So what is the serenity of prayer for culprit? Only God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. God grant me the serenity to accept the anatomies I should not attempt to revasc completely with harm. The courage to completely revasc critical only anatomies I should, and the wisdom to practice my treatment should not be worse than the disease itself. Cheap CTO, cheap CTO is like if you're talking too much about a small branch, it's almost like carrying your mother-in-law on the, like you're pulling your mother-in-law on another cart. So forget mother-in-law, protect yourself, be selfish sometimes. Perhaps some people do not need complete revascularization at all. The benefits of CR likely favors those at high risk of CV events and fewer competing risks. The risk of CR is more than the benefits supplying a small territory. Do not venture into that. Decision CTO trial did not demonstrate any difference in the symptoms of clinical outcomes with CTO PCI. So this is Banksy. The modern GDMT is an elephant in the room. Do critical only. And sometimes we know that from ischemia trial, revive trial, the GDMT and critical only lesion can do wonder. And what is the data? Either you believe God or believe the randomized clinical trial data. Everything is just intuitive, a conjectural, personal. So Sunita has mentioned that only one RCT in 2004, and which is neutral for shear or incomplete revascularization. Cheap shear is not always ideal for all patients. Beauty of shear is in the eye of the beholders. Like I'm a macho man, I have done all the PCI or all the territories, diagonal, left main, circumflex. I'm very happy, like Dr. Sunita. There must be reverse threshold. You should have a boundary, limitations. Primer, non-shear. The cheap patients are very sick. No point giving them benefit of doubt like cricket batsmen, as Bijay Trian was mentioning yesterday. Do not push hard the debate, Dr. Sunita, to intervention cardiologists who may not be able to perform shear in sick cheap patients. Where is the data on CABG? If you prolong your procedure, do 6-7 grafts, greater pump time, more blood transfusions, more stroke, more post-op AF, good progressions or greater progressions of native disease, and source of all the grafts are exhausted. And you have this data that Caray's body 2, PAM2, or beta ischemia. This Caray's is negative, body is negative on complete revasculations, PAM2 is negative, or beta negative, and ischemia is equipoise. The problem of randomization ischemia, like Dr. Lame, who presented this trial, she has seen the CT angio. So once you see something, and what has been seen can never be unseen. So all these trials have some biases, some conflicts, and they are not truly blinded. So volume increases, the contrast volume increases, the AKI incidence also increases in large number of patients. So immediate PCI versus culprit, definitely I'll go for culprit only, less hemodynamic challenge to the critical organs. The groin also cry. Groin, there is a bad memory of the groin and bad memory in the patient's mind. There is 10-year stitch data that young patients do benefit from CABG and PCI. But these are minorities. Where do you get 40 years man having a cheap, classical cheap patients? So revive data looks good, but some sub-analysis, like if you go for complete revascularization index more than 80, in one view, you can see that hazard ratio is 0.87, but if you look at the confidence, there is no confidence in the confidence interval. It has crossed 1. So quality of life important. There is a net loss. Initially you gain, but ultimately you lose. So these are the basic difference between these 3 trials, stitches, ischemia, revive. Viability test was done in revive BCIS. And left main 14%, severe LV dysfunction 27%, severe angina 23%, relevance particularly yes. So Sunita will scare you that he may die on the table if you go for a complete revascularization. But my patient, if I do culprit only, that will be less scary to the patient. So this is the best way of doing things. I have 3 more cards to play, ladies and gentlemen. You change your color, your strategy, your defense from the enemy with the situations. This small reptile is also behaving in the same manner, so it's coming from the nature. So if you have difficulties, you have to change your strategy in the war. So the reptile is slowly climbing, and according to the color of the bar, you will be surprised to see the real experiment actually proves. Give me 2 more minutes, sir. So how do I know I have done enough? I said it before, critical only, FFR and viability. I have 2 more cards to play. You know, those who listen to this song, John Lennon, give peace a chance. So my submission here, culprit, complete is a worth alternative to complete revascularization. In all, give me medical therapy a chance, give peace a chance to the human body and the heart, who are actually very sick. Small vessel disease, diffuse multiplicity of frail patient, high bleeding risk, anemic, blood transfusion, atrial fibrillation, oral anticoagulant, non-viable territory, and hemodynamic instability secondary last.
There's a blockage. Once they found the blockage, then they put a catheter in through an artery in the groin this morning, fed it up to the heart, put a balloon in and dilated the part of the artery that was closed and put a stent in, which is a very tiny thing I'm going to show.
I'm so curious about what the stent actually looks like.
Well,
We talk about it.
Yeah.
Sometimes we show animation, but you actually have one that you have permission to use
Right.
outside of a procedure. So
Well,
why
because
don't
they
you
want
lead
to,
us
even
with
though
that?
it's expensive, they want to show it off on TV. So a stent
gentleman
is
was
really
giving
tiny,
an
and it's fed up into the artery, and you leave it in there, and it keeps the artery open. So I'm going to open it.
How long can you leave it in there?
Well, it should stay in there for the rest of his life.
So would you have to replace it?
Hopefully not. Hopefully, once,
look at
after
his
it
back.
lasts about 6 months,
And he's a
it should be good to go
cardiologist,
after that.
Never
Okay,
entered
so
into
this is
any
this
of
is a
the
very
See if we can
typical
open it.
device. Maybe look,
And,
obviously
We can show it here. This is
he's trying
this
to
is the
open the
it
catheter.
needs to be sanitized, so we at least know it's
From the stent
sanitized.
box.
How much does that device or
And,
that cost?
I'm going to try to open it.
Look at here.
Do you do this in the operating room,
Look
doctor?
at
That's
it.
No
what-
teeth in the operating room.
We could have gotten you
So,
a pair of scissors. I mean,
even the
come
anchor is
on.
smiling.
We'll see if we
and
can
he will
open it.
fail.
Well, maybe you can do it.
Yeah,
He-
let me try. Here, Liz,
Now
I'm going to
he
give it
has
to you while we're
handed
working
over
on
the
it. I'm going to
stent
have Liz, our
to the
stage
anchor.
manager, help
Anchor
really get it open.
handed
over. Okay, here
But
it
here
is.
it is, Doc. Okay, we
Other
only have a
person
minute left, but at
is
least
looking
it
at the
shows us a little
stain,
bit
where
about
from
what
it
it looks
starts,
like.
where from it
And
ends.
we'll try to
So
hold
if
it
your
up to the
cheap
camera there. It is
patient goes
interesting
to a
to take a
person
look
like
at.
me
And you
who
feed it
doesn't
right
know
into-
even
into
how
the
to
groin.
open
But it's
that.
very, very,
Imagine
very,
what the
very
outcome
small,
will
Doc,
be.
right? Goes
With
right
that,
into the artery.
Very, very
Thank you for your
tiny.
kind attention. Thank you.
All right.